lymphatic system of the heart. And we'll also try to discuss the clinical divisions of the coronary arteries, and then the coronary blood vessel flow, what are the things which regulate the coronary blood flow. So we'll start with the coronary arteries, the anatomy, and embryology. So coming to the embryology of coronary artery development, the coronary embryogenesis is not fully understood by everyone. So the endocardium of the heart, it contributes to the coronary endothelium, and the epicardium contributes as a source of vascular smooth muscle cells, and which is regulated by VEGF signaling from myocardium. At day 25, discrete vascular plexus forms around the heart, and by 6 weeks, coronary vessels connect to the aorta. So the disruptions can lead to the coronary artery anomalies. So by 6 weeks of intrauterine life, the heart starts, beating. So coming to the anatomy, it consists of arterial supply, venous drainage, and lymphatic drainage. Arterial supply. So the cardiac muscle is supplied by the two coronary arteries. One is right coronary artery and the left coronary artery. And these coronary arteries have major branches which are located subepicardially. So coming to the origin of coronary arteries, the coronary arteries originate immediately just above the cusps of the aortic valve. As you can see here, a surgeon is standing on NCC, which is and it is written as number 1 and number 2. So the coronary arteries, they just originate above the aortic valve cusps. So the right and left coronary arteries, the right one is smaller than the left one, and it arises from the right coronary sinus, and it terminates by anastomosing with the left coronary artery. Whereas the left coronary artery, it is larger, and it arises from the left coronary sinus, and it terminates by anastomosing with the right coronary artery. So left coronary artery arises from the left coronary sinus of the aorta, and its course is anterior-inferior between the pulmonary trunk and left atrial appendage, and it bifurcates into left anterior descending artery and left circumflex artery, as you can see in the figure. And sometimes it can trifurcate also, giving as a RI or ramus intermedius. Its length typically it will be around 10 to 15 mm, and then it will start bifurcating. And the variance may be absent if LAD and left circumflex artery have separate origins. In the figure we can see that the left main coronary artery, it will go between the pulmonary trunk and the left atrial appendage, and then it will divide, trifurcate or bifurcate. Coming to the left anterior descending artery, it courses anteriorly and inferiorly in the anterior interventricular groove and extends towards the apex of the heart. And sometimes it can wrap around apex to supply the posterior interventricular grooves, and in rare cases it replaces the posterior descending artery. And 4% of patients have LAD bifurcates proximally and forming dual parallel LADs. So in this figure we can see the left main coronary artery is bifurcating into left anterior descending artery and left circumflex artery. And this left anterior descending artery, as you can see, it will course anteriorly and inferiorly in the interventricular grooves and extends towards the apex of the heart. And it gives certain branches. There are diagonal branches and septal branches. So the branches of the left anterior descending include diagonal arteries like 2 to 6, which supply the anterolateral wall of the left ventricle, and septal perforators around 3 to 5, which supplies the anterior 2/3 of the interventricular septum. First septal is the largest and reaches the tricuspid valve papillary muscle, whereas right ventricular branches it supplies the anterior RV wall, and it is often inconsistent or absent. Coming to the circumflex coronary artery, so it courses in the left atrioventricular groove, and it terminates before the posterior interventricular groove in 85 to 90% and continues as PDA in 10 to 15%, So whichever artery gives the PDA, a posterior descending artery, that is considered as the dominance. So if left coronary artery or left circumflex artery is giving the posterior descending artery, it is considered as left dominance, whereas right coronary artery, if it is giving the posterior descending artery, that is considered as right dominance. And the main branches of circumflex artery is, one is obtuse marginal arteries and left atrial branches, sinoatrial nodal artery in 40% of cases, AV nodal artery in 15 to 25% of cases of patients, and posterior descending artery in 15 to 25% is left circumflex is dominant. So obtuse marginal arteries, they supply the lateral wall, LV wall, and anterolateral papillary muscle. As you can see in the picture, it is the left circumflex artery coming from the left main coronary artery, and it is giving the obtuse marginal arteries. So we have again obtuse marginal will be one, like 2 to 3 branches. So there are variations in which we can see ramus intermedius. It's an extra branch from as a trifurcation, it gives the ramus intermedius from the left main coronary artery between the LAD and left circumflex, and it courses parallel to the diagonal arteries, and absent left main coronary artery around 1%, LAD and LCX will have a separate origin from aortic sinus via individual ostia. The clinical divisions of left coronary artery, it will be the proximal left anterior descending artery. Proximal will be from ostium to first major septal perforator, and mid is from first septal to second diagonal, and distal is from second diagonal to the termination. Whereas in left circumflex, proximal is ostium to first obtuse marginal, and mid is OM obtuse marginal 1 to obtuse marginal 2, whereas distal is obtuse marginal 2 to the termination. So coming to the right coronary artery, it originates from right coronary ostium and courses anteriorly and laterally into the right AV groove and travels infralaterally towards the acute margin of RV. And it wraps around the inferior heart surface, and it gives off the posterior descending artery and continues as posterior left ventricular artery. So as in this GIF, you can see how the right coronary artery runs and how it wraps around the inferior surface of the heart. Sinoatrial nodal artery, its origin is from right coronary artery in 55% and left circumflex in 45%, and course relative to SVC, superior vena cava and right atrial junction. Anteriorly 60%, posterior 33%, and encircling 7%. So these are the variations. And the other thing is infundibular or conus branch. It courses anteriorly over the RV infundibulum, and acute marginal branch runs along the acute margin of the right ventricle. So these are the branches of right coronary artery: sinoatrial nodal artery, and infundibular or conus branch artery, and acute marginal branch. So this is the figure in which it is showing the right circumflex, right coronary artery with their branches: SA nodal artery, and then conus branch, and we have acute marginal branch, and it will continue as posterior descending artery and or the posterior interventricular artery. So again we can see in this the way it is running between the SVC and the RA. So these are the variations of sinoatrial nodal artery, anterior, posterior, and encircling it. So these are the variations of sinoatrial nodal artery. So anterior right ventricular branches, it supply mainly the anterior free wall of the right ventricle, and AV nodal artery arises from the RCA in 45 to 55% of patients, and posterior descending artery present in 85 to 90%. And when said the dominance, as I have discussed before, so whichever artery gives the posterior descending artery, it's that dominance. And the posterior descending artery runs in posterior interventricular group and gives septal perforates on posterior 1/3 of the IV septum. And posterior left ventricular artery, it supplies posterior surface of the left ventricle. So the variations of right coronary artery, that can be a dual origin from aortic sinus, common variant, and early bifurcation. In 10%, RCA splits within a few millimeters of origin into two equal trunks. Third coronary artery, conus artery, arises separately from the aorta. Acute marginal artery crosses the diaphragmatic surface of right ventricle in 10 to 20%. So clinically, how we divide the right coronary artery is proximal, it is ostium to first main RV branch. From mid, it is first RV branch to acute marginal branch. Distal, acute margin to the crux. So this is the division. So this is the division of or supply of the coronary arteries to the heart, myocardium. So we can see the right coronary artery supplying the posterior wall of the left ventricle, posterior part of the septum and right ventricle. Whereas the LAD, it is supplying the anterior wall of the left ventricle, anterior part of the septum. And the left circumflex, it is supplying mainly the lateral wall of the left ventricle. And again, this is coronary arterial distribution. So here again we can see the color graded where the LED is supplying what. So in this is in 4 chamber, 2 chamber along the like echo views, long axis view apex. So which part supplies what. And this is again ECG showing if it's an RCA lesion, so we can find some changes in 2-3 AVS. And if it is LAD, then we can find some changes in V1, V2, V3, V4. So it's again how we can interpret the arterial lesions according from the ECG changes. Coronary blood supply to conduction system. So SA node, mainly the right coronary artery in 55 to 60% of patients, and the left circumflex artery in 40 to 45% of patients is seen. And AV node is supplied by RCA in 90% of patients, and bundle of SS by RCA or LAD. Right bundle branch from again LAD. Left bundle branch, anticus and posteriors, again it is LAD or RCA. As I discussed previously, so the dominance is mainly defined by the artery which is supplying the posterior descending artery. So the PDA is supplied, if it is formed from the left circumflex, then it is left dominance. If PDA is formed from the right coronary artery, then it is right dominance. And sometimes there can be codominance also. As we discussed, in this we have to discuss codominance, balanced circulation. That is, the PDA is supplied by both RCA and LCX. It is observed in 7 to 10% of the population. Mostly the individuals are right dominance, like 80 to 85%, and left dominance around 8 to 10%. The functional division of coronary arteries: epicardial vessels, conductance vessels; intramyocardial vessels, they are resistance vessels; subendocardial vessels, they are end vessels. So in this picture we can see the epicardial vessel which stays on the surface of the heart and which is inside the myocardium. They are intramyocardial, they are resistance vessels. And we can see the subendocardial vessels, they are end vessels through which the perfusion happens. So the collateral circulation of heart, the coronary collaterals functions as natural bypass. So they are anastomotic connections that lack intervening capillary networks. So these connections occur between the segments of either same or different coronary arteries. They form as a response of chronic ischemia, and their role is to supply alternative blood flow when the primary vessel is narrowed or blocked. So they contribute to maintaining myocardial function in cases of coronary artery disease. So in this angiogram we can see RCA is joining with LCX by collaterals. So it mainly because of the chronic ischemia. The clinical factors that influence collaterals are degree of coronary artery stenosis, proximal lesion location, longer duration of symptoms, and longer duration of lesion occlusion and heart rate. So the degree of coronary stenosis is considered the strongest predictor, confirmed in several studies. So the mechanisms for stimulating collateral growth is, one is tangential wall stress. Due to ischemia or overstretching, it triggers the cellular proliferation, and the other one is pressure gradient between the patent and obstructed arteries, drives the vascular remodeling. The other one, intraluminal pressure. Pressure itself promotes vessel growth, and increased flow velocity. Occlusion creates pressure drop, and that causes flow through the collaterals increase, and it stimulates the growth. Hypoxia is again one important thing. The low oxygen tension it triggers the angiogenesis and metabolic accumulation, which due to buildup of like waste products, metabolic waste products, it stimulates the collateral development. In this, we can see a circle of Wiesen's. It's an important coronary collateral pathway. It connects the RCA via conus artery to LAD and provides an alternative flow in case of stenosis in right coronary or LAD. In this angiogram photo, we can see collateral to distal LAD from RCA. So you can see that, and from collateral to the proximal LAD. This is mainly because of coronary artery stenosis or cutoff. And this we can see RCA to obtuse marginal collateral following the left circumflex total occlusion. In this other picture, we can see LAD to PDA collateral filling following the right coronary artery total occlusion. Coming to the venous drainage of heart, the main thing in heart is coronary sinus. It is the main venous channel, and it lies in the posterior AV groove, and it is a continuation of the great cardiac vein. And the other thing is anterior cardiac vein, middle and small cardiac veins, and vena cordis minime. So the anterior cardiac veins, it drain directly into the right atrium, and middle and small cardiac veins, they drain posterior heart regions. Vena cordis, these are Thebesian veins. These are the smallest veins which directly drain into all chambers, mainly into the right atrium. So in the picture, you can see the coronary sinus, which usually lies in the posterior AV groove, and it is a continuation of the great cardiac vein. So coronary sinus, it lies in posterior part of the coronary sulcus, and it ends in the right atrium. Great cardiac vein, it starts on the anterior surface of the heart near the apex and runs with the anterior interventricular artery, turns to the left with circumflex artery in the coronary sulcus, and it ends joining the left end of the coronary sinus. Left marginal vein ascends along with the left margin of the heart and ends by joining the great cardiac vein. Oblique vein, it begins on the posterior surface of the left atrium and join the left end of the coronary sinus. Left posterior ventricular vein, it runs on the diaphragm surface and diaphragmatic surface of the left ventricle of the coronary sinus. Middle cardiac vein, small cardiac vein. Middle cardiac vein, it begins on the inferior surface of the heart near the apex, and it runs the posterior interventricular artery and join the middle of the coronary sinus. It may join the great cardiac vein. Small cardiac vein, it starts on the anterior surface and runs over the right marginal artery and join the right end of the coronary sinus. Anterior cardiac veins, these veins drain anterior wall of the right ventricle into the right atrium, whereas small vein, vena cordis minime, these are present in all the chambers and they direct drain into the right atrium. Lymphatic drainage of the heart, they follow the coronary arteries along their course from two main lymphatic trunks. One is right trunk and left trunk. Right trunk drains into brachiocephalic lymph node, and the left trunk drains into tracheobronchial lymph nodes located in the tracheal bifurcation. So how the coronary blood flow is regulated? So normally the coronary blood flow is 0.6 to 0.8 ml per gram per minute, which is approximately 250 ml per minute, that is 5% of the cardiac output. So during exercise, there is four-fold increase of the coronary blood flow, which is up to around 1000 ml per minute. The factors affecting the coronary blood flow, mainly the mechanical, metabolic and hormonal and neural. The mechanical factors are phasic blood flow and blood flow autoregulation and regional differences in blood flow. The phasic flow, coronary flow varies with cardiac cycle phases determined by the aortic pressure, the pressure at versus the intramyocardial pressure. Left ventricle and reduced flow in the systoles, maximal in diastole. So whereas in right ventricle it receives the flow during both systole as well as diastole, and there is less intramural pressure and less compression during systole. So the left ventricle usually gets its right ventricle receives the coronary blood flow during both the systole and diastole, whereas in left ventricle the flow is reduced in systole and maximal in diastole. Even in this graph we can see the phasic coronary blood flow, the aortic pressures and the right coronary artery and left coronary artery pressures. This is the coronary filling pressure. So the right coronary flow is less affected during systole, and aortic RV pressure gradient is greater in systole than diastole. It enables the systolic perfusion of the right ventricle. Unlike the left ventricle, right ventricle receives blood flow in both systole and diastole. So in this table we can see the pressure differences in aorta, left ventricle, right ventricle, and so that we can see that in RV, right ventricle, the blood flow can be happen in both diastole and systole, because the pressures in systole is 25 and whereas in left ventricle and aorta it is 120. So the pressure differences, because of that the coronary blood flow occurs in both systole and diastole in right ventricle. These are the LV coronary filling pressures, whereas RV coronary filling pressures. We can see almost there is no gradient, which means there is no coronary filling, whereas in right ventricle coronary filling pressure there is gradient, so there is flow. Autoregulation of coronary blood flow, the ability of the heart to maintain flow constant in face of change in the perfusion pressure without intervention of any other mechanisms. So the metabolic factors are vasodilators and vasoconstrictors. Adenosine and its compounds like potassium, hydrogen, calcium ions, carbon dioxide and oxygen, these are all the vasodilators, prostaglandins, whereas vasoconstrictors, thromboxane A2, endothelin, prostacyclin I, bradykinin and angiotensin II. Neural factors, sympathetic, the widespread influence of epicardial vessels, because they have alpha receptors which leads to vasoconstriction, and while endocardial vessels have beta receptors resulting vasodilatation. And parasympathetic, the minimal effect and primarily causing vasodilatation. Coronary circulation, the clinical aspects are, so it is mainly divided into atherosclerotic coronary disease and non-atherosclerotic coronary disease. So in atherosclerotic coronary disease, we know we usually operate in such cases, whereas atherosclerosis of coronary disease, we do coronary artery bypass grafting. Whereas non-atherosclerotic coronary artery disease, there are anomalous aortic origin of coronary arteries, anomalous pulmonary origin of coronary arteries, single coronary artery, left main coronary artery atresia, coronary artery fistula, muscle bridge, and coronary aneurysms like coronary artery ectasia and dilating coronary atherosclerosis, coronary artery dissections. So these are the non-atherosclerotic coronary artery disease, the variations, and other is coronary artery atherosclerotic disease. So coming to the other aspects of how we have the views for the coronary arteries, like cath, during the cath, how the CM to be manipulated for which artery, for example, left coronary artery, how do we see from the cath lab view, that we'll be discussing later. So this comes to the conclusion, and till now we discussed about the anatomy of coronary arteries and how the clinical divisions of each coronary artery, left anterior descending artery, how it is divided, left circumflex artery, how it is divided, right coronary artery, how it is divided, and what are the parts of myocardium that are perfused by different coronary arteries. And also we had seen the venous drainage of the heart, where is the coronary sinus located, and also we had seen the lymphatic drainage of the heart, and we also had seen the phases of coronary artery circulation and its regulation. And we also had seen the arterial supply of nodes. We also have discussed about the dominance, left dominance, right dominance. And coming to the cath views, how to identify which artery based on the cath. So that we'll be discussing in further presentations. Thanks a lot. Thank you.